To a very interesting session by none other than Dr. Vijay Kher, who's a globally renowned nephrologist, professor head department at the Max Hospital, Delhi. And the chairpersons for this session are Dr. Sangram Vidar and Dr. Bhattacharya. Over to Dr. Sangram to initiate the session. Dr. Sangram.
Yeah, a very good morning to one and all. I thank Dr. Manoria sir for giving me an opportunity. Now I invite Dr. Vijay Kher to speak on Finerenone in for cardiorenal benefit. Dr. Finerenone has already been introduced by Dr. Manoria sir. Over to you, Dr. Vijay.
Thank you. Thank you. I must at the outset thank Dr. Manoria for giving me this opportunity to come and talk to you. And after a wonderful talk, a very inspiring talk by Dr. Mala, I think Finerenone is obviously a drug which is used in late stages of complications of cardiometabolic syndrome. Next one, please. Most of us have been using, next slide, please. Most of us have been using, can I change my slides? If you can give me control, then maybe I could. Most of us have been knowing that mineralocorticoid receptor activation and inhibition is involved in cardiac failure. And cardiologists have been using aldactone and eplerenone, which are steroidal mineralocorticoid receptor antagonists. And the Finerenone is a newer non-steroidal mineralocorticoid receptor activator. And we have always known that mineralocorticoid activation is one of the processes of progression of both cardiovascular, and more recently we've got to know that it's also involved in progression of kidney disease. And obviously the progression of chronic kidney disease and cardiovascular disease occurs both in diabetes, as well as we know that these processes occur in non-diabetic patients also, because these drugs have been shown to be effective even in non-diabetic patients. So there are hemodynamic factors, metabolic factors, and there has been a factor of inflammation and fibrosis, which occurs both in progression of chronic kidney disease with tubulointerstitial fibrosis, glomerulosclerosis, mesangial expansion, and glomerular hypertrophy. These are both progression of inflammation, which is shown to occur in patients with chronic kidney disease, as well as hemodynamic and metabolic factors leading to progression and fibrosis, tubulointerstitial fibrosis, as well as glomerular hypertrophy because of the hemodynamic factors. Similar factors have been associated with cardiovascular disease progression in form of myocardial fibrosis, increase in atherosclerosis, vascular stiffness, endothelial damage, and ventricular hypertrophy. Next one, please. And the current therapies for patients both with heart failure as well as with patients with chronic kidney disease have been ACE and ARBs, which also have an angiotensin aldosterone inhibition action, and they act predominantly through a hemodynamic factor. Obviously, SGLT2 inhibitor, GLP-1 agonist, metformin, and other drugs are used for control of metabolic factors like control of diabetes and other effects. And the newer Finerenone, which is the factor which affects inflammation and fibrosis, has been demonstrated both in diabetes and non-diabetes. And as I said earlier, the cardiologists have already been using these drugs, except that the Finerenone provides a different and a newer aspect to inhibit inflammation and fibrosis. Next one, please. And this is MR overactivation has already been shown to cause worsening of cardiac failure as well as progression of chronic kidney disease. And aldosterone, cortisol, and oxidative stress activation have already been demonstrated to be pathogenic for progression of both heart failure and kidney disease. Next one, please. And the Finerenone is a non-steroidal selective mineralocorticoid receptor antagonist and inhibits mineralocorticoid receptor overactivation, and therefore stops the process or inhibits the process of through hemodynamic factors, as well as incorporating inhibition of inflammation and fibrosis, and decreases significantly albuminuria. And albuminuria, as you all know, is not only a factor for progression of kidney disease, but factor responsible, independent risk factor for cardiovascular mortality, overall all-cause mortality, as well as for progression of kidney disease and development of end-stage kidney disease. Next one, please. So albuminuria reduction is an important cardiovascular risk protection factor. So decrease in albuminuria, and I'm glad to say that cardiologists have now started looking at albuminuria as a marker for cardiotoxicity and not only for kidney toxicity. And keeping kidney function in a normal range or under control is an important risk factor reduction for managing cardiac disease as well. And as is shown in this cartoon, this is mineralocorticoid, the steroidal antagonist, which cardiologists have been using previously, and the Finerenone, which is a non-steroidal, has a greater affinity and selectivity for mineralocorticoid receptor, has a short duration of action, doesn't have the adverse effects of aldactone and eplerenone, and has a milder effect on control of blood pressure. Next one, please. And as we know that despite availability of the renin-angiotensin blockade, availability of SGLT2 inhibitor, as was shown in Credence, DAPA, as well as AMPA-CKD study, which was done both. The AMPA and DAPA-CKD study was again done both in diabetics and non-diabetics as well. And you can see that there is still a residual effect both on cardiovascular as well as on the renal disease. So there is an additional need, and cardiologists have also told us that with these pillar drugs, so you add another pillar of therapeutic intervention by which you might reduce the residual diseases further. And so combining these pillars is able to help reduce the burden of disease, residual disease, to a significant extent. And Finerenone is an additional drug which reduces the residual cardiovascular and renal disease by decreasing this residual disease despite usage of ACE inhibitors, SGLT2 inhibitors. And so this is another third pillar which is used in chronic kidney disease progression reduction as well as in cardiovascular disease reduction. Next one. And so a holistic treatment of combining RAS inhibition, SGLT2 inhibitor, Finerenone, and maybe a GLP-1 receptor agonist would provide all the four pillars in the management of cardiorenal metabolic syndrome in patients of heart disease and kidney disease. Next one. Finerenone, there were the initial phase 2 studies, and then there were two large, very large studies which were done for cardiovascular disease as a primary outcome in Figaro's diabetic kidney disease. These were done in diabetes. And then there was a fine arts study, which was a heart failure study where Finerenone was used in diabetic as well as in the non-diabetic patients. And Fidelio was a trial, large number of trial of about 6,000 patients, which were kidney outcomes, composite kidney outcomes were the primary failure, primary outcome measures, and the cardiovascular disease were secondary outcome measures. In Figaro, cardiovascular disease outcomes were the primary and kidney disease outcomes were the secondary. So the combined data was analyzed by Fidelity. Next one. And you can see that this is the Fidelity, basically looking at it. The Fidelio had, as I said, the kidney outcomes as the primary one, and Figaro had diabetic, the cardiovascular outcome. There was a 4 to 16 weeks of run-in period, and then 10 milligrams or 20 milligrams of Finerenone was used, and about 13,000 to 14,000 patients were looked at in both these trials. Next one. I'll present the data on the Fidelity, which was a pre-specified pooled analysis, and that's the data which I'm going to present in the next few minutes. Next one. And here you have, these are type 2 diabetes, chronic kidney disease patients who were optimized on RAS inhibition, serum potassium of about less than 4.8, and they had HFrEF and Y2. These were not there in these patients. So key outcomes were cardiovascular outcomes as well as composite kidney outcomes, which was more than time to kidney failure, more than 57% eGFR kidney composite, sustained reduction in GFR from the baseline or renal death. Next one. And if you look at the ages were around about 65, 70% were males. hemoglobin A1C of 7.7. Blood pressures, history of cardiovascular disease was present in about 46%, heart failure in about 7.7%. Potassium was 4.4. So majority of these patients, almost everybody was on RAS inhibition, 72% were on statins, beta blockers, calcium antagonists. And you can see that only few percentage of patients were on SGLT2 inhibitors and GLP-1 regulators. About 15% of patients on these drugs. Next one. And you can see that the Finerenone reduced urinary albumin excretion rate by about 32% from baseline at month 4. And this was next one, please.
Professor Kher, you have been muted. Professor Kher, you have been muted, please.
Dr. Kher, please.
So, can you hear me now?
Yes,
Hello,
sir. Yes.
can
Yes,
you hear
yes.
me now? Yeah.
Yes, sir.
So in fidelity, Finerenone significantly reduced the risk of kidney composite outcome by about 23% and ESKD by about 20%. And next one. And you can see that this reduction in kidney composite outcomes were irrespective of the baseline eGFR or urinary albumin creatinine. So it didn't matter whether the GFR was 25 to 45 or it was more than 60. If you look at the interaction, there was no significant interaction. So these factors were not independently effective. So it didn't matter whether the patients had a low GFR or a higher GFR, or they had a lower degree of albuminuria or greater degree of albuminuria. The impact on reduction of kidney outcome was similar. Next one, please. And this was cardiovascular morbidity and mortality, which was reduced by significantly reduced by about 14%. And you can see that these were the effects. Next one. And it also didn't matter whether the GFR was lower. The cardiovascular outcomes were similar, irrespective of the level of GFR or irrespective of the level of urinary albumin creatinine ratio. Next one. Finerenone demonstrated significant on-treatment reduction in incidence of all-cause and cardiovascular mortality versus and lowered the risk of sudden cardiac death in patients of intention to treat population. And so you can see that the sudden cardiac death was also, and those on treatment, all-cause mortality and cardiovascular mortality was lowered to a significant extent. Next one. Finerenone improved cardiovascular and heart failure outcomes in patients with chronic kidney disease and diabetes by 22% reduction of risk of first hospitalization for heart failure and 32% reduction of new onset heart failure in patients. So therefore, it is being recommended by the European Cardiology Association as the drug for prevention of heart failure in patients of chronic kidney disease and type 2 diabetes. Next one. Fidelity, when you look at the SGLT2, small number of patients were there in the SGLT2. Those who were on SGLT2 and Finerenone, you could see that when you compare them with those without SGLT2 and those with SGLT2, the reduction in albuminuria was almost a similar extent, although slightly greater reduction in albuminuria in patients who were also on SGLT2. There is a confidence trial which was happening in about 800 patients. The data is already out, and this was done in patients who were already on with SGLT2, and combination of SGLT2 and Finerenone together at the same time did result in greater reduction in albuminuria in the confidence trial, and that trial is about to be published. Next one, please. So the predominant complication of use of Finerenone is predominantly hyperkalemia, and one was to look at the safety of this trial. Next one. So this turned out to be that there was no effect on hemoglobin A1C, there were no breast-related side effects, and the modest effect on systolic blood pressure. So the effect was not as high as the steroidal MR antagonist. Next one. Therefore, based on these trials, the fidelity data guidelines, both in 22, 23, and 24, the KDIGO guidelines, as well as ADA and the ESC, as well as the American Heart Association, most of these associations have recommended Finerenone to be level A kind of a recommendations for both control of heart failure as well as for control of composite kidney outcomes. So a drug which can be used in patients with cardiac disease for prevention and treatment of heart failure in patients with cardiovascular disease as a fourth pillar of treatment, and a third pillar of treatment after ACE inhibitors, SGLT2 inhibitors, and Finerenone to be added in patients with diabetes and without diabetes. At the moment, the CKD study on without diabetes is still continuing, so we don't have this data. I would expect this data also to be there, because the Fine Art study, which looked at both diabetes and non-diabetes in heart failure, it was found to be effective both in non-diabetic as well as in diabetic heart failure patients. Next one, please. So this is the third pillar that I was talking about, that one could add Finerenone as a drug to prevent progression of chronic kidney disease as well as progression of heart disease in patients with diabetes and non-diabetes. Next one. There are real world life data as well, Fountain and Fine Real, and these again. Next one, please. Please go ahead quickly, because this data again emphasizes that in the real world in the US and in other countries. Next one. You can see that 49.4% patients had RAS inhibition, 38% patients in the real world were using SGLT2 inhibitors along with it, and about 25.6% of patients were using also GLP-1 receptor agonist along with Finerenone in the real world. Next one. And you could see that patients with all categories of albuminuria, Finerenone is being used. Less than 30, moderately increased albuminuria, 39%, and about 40% more than 300 milligrams per gram creatinine. Yeah. Next one. And you can see that the Finerenone was associated with greater decrease in urinary albumin excretion rate in all the categories. Next one. Greater reduction in UACR when you combine SGLT2 inhibitors with Finerenone. I told you that there's a separate study of Confidence, which was also has data of about 800 patients, which is to be published yet, but the data is out, and it shows greater effects on reduction in urinary albumin excretion. Next one, please. In the US patients, the risk of hyperkalemia, you can see in the real world, is about 1.3%, and hyperkalemia which required admission in the hospital or hospitalization is extremely low, 0.04%. So one should be able to use these drugs in the vast majority of your day-to-day practice patients. Next one. There was a guideline on the practical usage of this when Figaro and Fidelio were being tried. And next one. So you can see that you could use starting dose as 10 milligrams. The optimal dose maximized was about 20 milligrams. And in the ARTS diabetes trial, obviously higher dosages produced greater reduction in urine albumin granulation. Next one. And this was the potassium. You would go to 10 milligrams. If the potassium was less than 4.8 and less than 5, then you would go to a 20 milligram dose. And if the potassium remained all right, that was okay. But if potassium went up and it didn't come down with dietary modifications, you would reduce the dose back to 10 milligram. And once the potassium was controlled, try to increase it. So this was a method used in these trials to monitor for potassium and keep the potassium within the reasonable range. Next one. I usually don't get worried about many of these patients till about 5.5 potassium, and my trigger to sort of cut down or get involved is when the potassiums tend to go up between 5.5 to 6 milliequivalents per liter. So to summarize, mineralocorticoid receptor overactivation, which contributes to inflammation and fibrosis, is a potential treatment target to slow cardiovascular disease as well as chronic kidney disease. Holistic treatment approaches for management of cardiovascular disease and chronic kidney disease there are 3 different pathways to slow the progression of heart and kidney disease. And I think all 3 must be utilized in retarding the severity and retard the progression of these diseases. Despite RAS blockade and SGLT2 inhibition, patients are still having residual risk progression for chronic kidney disease and cardiovascular disease. And Finerenone as a non-steroidal selective mineralocorticoid receptor antagonist is much different from the steroidal mineralocorticoid receptors and provide a very good therapeutic opportunity for reducing mineralocorticoid overactivity, and is now recommended along with other medications for cardiovascular and kidney protection and mitigation of the cardiovascular disease. And this is not used only as an alternative, but used in combination for optimal benefits. Thank you very much for your patient care.
Thank you, sir, for an excellent deliberation.
Can I have a few questions, sir?
Yes.
I'm Dr. Amal Bhattacharya.
Yes.
Yeah. So, sir, excellent deliberation and
Thank you.
made the topic, difficult topic, simple. Sir, this same thing can be extrapolated in type 1 also?
Type 1, this has not been used. SGLT2 inhibitors are not used in these, and Finerenone have not been used also. But I would guess that they should be okay in type 1 disease as well.
And what are the site on the kidney the Finerenone acts?
Site, it
Yes.
acts on the mineralocorticoid receptor activation, and mineralocorticoids have been, overactivation has been incriminated both in aggravating inflammation in the kidney as well as in the gut, and decreases renal fibrosis. That's what the mechanism is. This is
Sir,
because
as you
of
mentioned,
this
Sir,
is
as you
because of the
mentioned about-
reduction. This
Yes,
is
sir.
reduction in the downstream regulation, metabolic regulation, as well as antifibrotic regulation in the kidney.
Sir, half-life is very, very short.
Yeah. As well.
And we are giving once a day. Is it
Yeah,
enough?
but it has a very high selectivity for the receptor activation, and does have an effect, prolonged effect. And as the downstream effects have been probably related to the signal transduction in the cells, so probably those effects are being shown to be consistently inhibited for a prolonged period of time.
Sir, in Mumbai, we already see people with potassium level of 4.5 around. Commonly, we see this. And then one has to go into details of the diet, because there is a fashion to take two coconut water every day, take a lot of fruit juices. This is the fashion, so one has to go into the details.
One will have to talk to the patients when you start these drugs. And these patients are also on, usually many of those patients with cardiology will be on ARNI. And some of these patients will be also on ACE inhibitors or angiotensin receptor blockers, which also increase potassium. So one will have to always talk to the patient about the dietary things when you start these drugs, so that they don't take high potassium diets. Although diet contributes to only about 10 to 20% of the potassium that is regulated in the body. It is obviously a metabolic product in the body, which metabolism, that's what it causes. But still, obviously, when you are using these drugs in combination, especially with ACE and ARBs, the potential for hyperkalemia would be there. So one will have to educate your patients. But as has been seen both in these studies of about 15,000 patients and then real world data, the incidence of hyperkalemia or severe hyperkalemia is not very high. You should be able to use these very effective drugs in combination as a pillar therapy for majority of your patients. There will be occasional patients who may be at high risk of potassium, where one may not be able to use it or use lower doses of these drugs. How I use these drugs in my practice is that many of my patients are acidotic, and therefore I have to give soda bicarb to these patients, and I add a small dose of a diuretic, usually a furosemide or a torsemide, small dose, to sort of increase the potassium excretion and also help in maintaining potassium in these patients. So many of these patients may have a small dose of a diuretic acidosis correction might help in many of my patients because that pushes potassium intracellularly and doesn't allow the potassium to go that high. So these
Right,
are the
sir.
other methods which might be useful.
Thank
So
you, sir.
over and
the
yeah,
clinical
yes, sir.
trials, the Finerenone has been used on top of maximally tolerated dose of ACE or ARB.
Yes.
Now, can we use de novo on day one?
Yeah, you could use. People have looked at data now, which have looked at, but there wasn't a significant number of patients who were not using ACE and ARB, so we don't have data by and large in these trials. But in real world, the US, the Fountain and the trial, there are only about 40% of patients were on ACE and ARBs, and there were many patients who were started with Finerenone or with SGLT2 inhibitors only, and ACE and ARBs were not possible, especially in patients who are not hypertensive, and many of my patients who are very low low blood pressures, you may not be able to use ACE and ARBs. So in them, SGLT2 and Finerenone could be used as these drugs, and they have been shown to be effective.
Sir,
in
over and
contrast
above
to-
CV reduction. Yes, sir. Sir, over and above CV reduction in a patient of diabetes with CKD, any other indication of Finerenone?
Albuminuria. So every patient of almost chronic kidney disease would fall into the indication for Finerenone predominantly, because albuminuria itself is a very high risk factor for both cardiovascular disease as well as for progression of kidney disease. So any degree of albuminuria which is higher, and as I showed you that in US real world study, 20% of patients who had normal albuminuria were also being used for Finerenone, and that may be an indication for heart failure along with patients with kidney disease, and these drugs are going to be effective in them irrespective of the degree of albuminuria.
Dr. Kher,
Thank you, sir. Excellent lecture.
all
Thank
these
you.
three, Dr. Kher, these three drugs are useful only in proteinuric nephropathy, or they are useful in non-proteinuric?
They are useful. They have been, the Finerenone CKD trial is not yet out, so this is an ongoing trial, but these are patients which were looked predominantly in the diabetic patients were with some degree of albuminuria and some degree of GFR reduction. So, but in the real world, they have been used in patients where the albumin excretion has been less than 30 milligrams, and they have been found to be useful. They have been found.
All these three drugs provide incremental benefit on top of each other.
Yes, yes.
Do you have any
That's
trial of triple combination? You have shown
yes,
trial
a
of
triple
both of them.
combination. Yes, the question predominantly initially has been that many of us use these as, do we start with ACE and ARBs, or many patients will be on ACE and ARBs, then we add an SGLT2 inhibitor, and since the albuminuria is not reduced completely, you add a Finerenone also on these drugs. So when you combine these drugs, now there are therapies which have been looking at combining SGLT2 inhibitor and Finerenone from day one itself, not waiting and adding it after few weeks or few months.
Suppose patient develop hyperkalemia, he's on all the three drugs. What will be your strategy?
Yeah, you would, if they are on the maximal dosage, you will reduce the dose. And if the potassium gets corrected, then you will continue that dose for some period and then try to increase the dose again after you reinforce potassium restriction in the diet. But if you can't use it, you will continue the lower dosages which are tolerable. And if one is not able to use one of these drugs, then as I said, that I would usually add a diuretic along with a soda bicarbonate. In many of my patients, acidosis is there, that would also increase hyperkalemia.
One of the attendees is asking how often potassium should be monitored when you do drugs.
Usually when you use this drug, then in about 1 to 2 weeks time, you should monitor it when you are increasing the dose. Otherwise, you should be monitoring it in about 3 to 4 months time.
Sir, in real world, we are seeing that in diabetic kidney disease, it is a very useful drug, but not being used. I have not seen many people using it, because in contrast to your renal patients, these patients are not coming regularly for follow-up. The diabetic patients, they are not doing their potassiums regularly. And also, we are not using too much of these diuretics, and soda bicarb is not there to be used in this diabetic kidney disease. So that is the reason I think in real world it is not picked up that much as its usefulness is shown in studies.
Yeah, I would agree, but this is something which is, these studies have started coming in the last few years, and I think drug sort of intake amongst the physicians and patients is always slower. Most doctors would want to see first, let the other doctors use it and see how they are using it and all that. So this experience, as for every other drug, new drug that has come, the intake has always been slower and all that. And I don't deny that that's something that every physician would like to look at the benefits in their patients, and then only once they feel convinced that they are going to see benefits and not see adverse effect, then they will use it. But I agree with you that the usage has not been as good and as effective as it should be, because these are beneficial drugs for the patients. And one does worry about potassium, because one episode of hyperkalemia, bad hyperkalemia, creates a lasting impression on doctors' mind, and they get worried. But as is shown in the real world data as well as in the studies, the incidence of hyperkalemia is not very high, and severe hyperkalemia occurs very, very rarely.
Thank you, sir.
With this, we conclude this session.